Hey everyone, welcome back. And if you are joining us for the first time, I am so glad you're here. But I do want to let you know that today's episode is a part 2 of a conversation we started in episode 4. And if you haven't watched that one yet, I would strongly encourage you to go back and start there. The link is in the description and comments below. Here's why it matters. Everything we're about to talk about today builds on the foundation we laid in part 1. We covered how insurance companies write their own medical policies before your procedure ever happens. We broke down the real difference between prior authorization and predetermination and what it actually means when a payer tells you they won't offer one either. And we had an incredible in-depth conversation with Dina, a prior authorization specialist with over 18 years of experience in interventional radiology, who shared some of the most practical inside the process insight I think this channel has ever featured. If you watched part 1, welcome back. I'm glad you stayed with us. Now, let's get into the part nobody likes to talk about. Because up until now, we've been talking about process, policies, paperwork, definitions. What we're covering today is what happens when that process fails, and it fails more often than it should. We're talking about patients waiting for care they needed yesterday. We're talking about physicians burning out, fighting battles they shouldn't have to fight. We're talking about the staggering invisible costs that are draining healthcare organizations from the inside out. And we're talking about the moment every patient fears most, opening a bill of care they thought was covered and realizing the system left them completely exposed. This is the part that has real consequences for real people. And understanding it, whether you are a patient, a practice manager, or a healthcare leader, is how you stop being a victim and you start being someone who knows how to fight back. Let's get into it. Let's talk about what happens while all of this is being processed. Delays. Prior authorization timelines vary by payer, by service type, and by how backlogged the review team is. Non-urgent requests can take days. Complex cases can take weeks. And during those weeks, your patient, a real person with a real condition, is waiting. For urgent procedures, this is not just frustrating, it can be really dangerous. Imagine your doctor identifies a suspicious mass and orders a PET scan. The insurance company requires prior auth. The request goes in. They ask for additional clinical notes. The office sends them. They need a peer review. That takes a few more days. Maybe the initial request got denied. Now there's an appeal. Meanwhile, you, the patient, are sitting at home waiting, worried, not knowing what's happening to your body. Studies have shown that prior authorization delays contribute to patients abandoning recommended treatments, experiencing disease progression, and in some cases, ending up in the hospital with conditions that could have been managed earlier. And in serious cases, it means irreversible harm. The American Medical Association has documented year after year that a significant portion of physicians report prior authorization had led to a serious adverse outcome for at least one patient. Not a billing issue, not a paperwork problem, a health outcome. Red tape has consequences that go well beyond the balance sheet. For patients, if your procedure is being delayed by a prior authorization, you don't have to wait passively. Call your insurance company and ask for a status update. Ask if you can request an expedited review. If your condition is urgent or could deteriorate, most payers are required to process expedited requests within 72 hours or less. Your doctor can help support that request with clinical documentation. For practice managers, build a daily authorization tracking workflow. Every pending auth should have a follow-up date. Don't wait for insurance companies to call you. They won't. Your team should be proactively checking status, escalating stalled requests, and flagging clinical urgency to reviewing bodies when appropriate. Every day a patient waits is a day of clinical risk and a day your schedule is in limbo. For healthcare leaders, track authorization turnaround time by payer as a KPI. You should know which payers are chronically slow. That data has value in payer contract negotiations. It also tells you where to focus staffing resources. If one payer is responsible for 40% of your authorization delays, that's a problem requiring a structural solution, not just more follow-up calls. Let me be honest about what the system is doing to physicians. Doctors didn't go to medical school to spend hours on the phone with insurance companies. They went to practice medicine, to diagnose, to treat, to heal. What prior authorization has done is insert a mandatory administrative obstacle between a physician's clinical judgment and the patient's care, and physicians are exhausted by it. The AMA has reported that physicians and their staff spend an average of 2 full business days per week on prior authorization tasks. That's 2 full days per week. That is time stolen from patient care. every single week at every practice in this country. The emotional toll compounds. When a physician's medically sound, well reasoned decision is second guessed by a reviewer at an insurance company, someone who has spent maybe minutes on a file the physician has spent months building, that is demoralizing. And it is a primary driver of physician burnout. We are losing physicians to the system, and we are not talking about it loudly enough. For patients, when your doctor seems frustrated, when they are on the phone fighting for your care, know that they are advocating for you against a system that routinely works against both of you. Thank them. And when you have the opportunity in surveys, in reviews, or in conversations with your employer's benefit coordinator, say clearly that you want insurance processes that respect your doctor's judgment. For practice managers, protect your physician's time. Every minute a physician spends on an authorization call is a minute they're not seeing patients. And in many practices, that is direct revenue loss on top of morale cost. Build a support structure, authorization specialists, train front end staff, a peer to peer scheduling system that doesn't require the physician to be on hold. Give them back their time. For healthcare leaders, this is your workforce crisis. Prior authorization burden is measurable, and it is directly tied to physician satisfaction scores and turnover. When you're calculating the cost of replacing a physician, recruiting, credentialing, lost productivity, patient attrition, that number is in the hundreds of thousands of dollars. If your authorization workflows are contributing to physician burnout, the ROI on fixing them is enormous. This belongs on your strategic agenda. There's a financial reality to prior authorization that most organizations don't fully account for. The staff time consumed by this process is staggering, and it's rarely measured accurately. In every medical practice, whether it's a small family practice or a large hospital system, there are people whose entire job is navigating insurance authorizations. Sometimes it's a dedicated authorization team, sometimes it falls on the front desk, the medical assistants, the nurses. These staff members are spending hours, sometimes their entire day, on hold with the insurance companies, uploading clinical documentation, responding to requests for more information, tracking pending authorizations, and following up on delayed decisions. This is not free labor. This costs the practice money. And guess what? Those costs get passed along through higher fees, through reduced capacity, through staff burnout and turnover. One study estimated that the administrative cost of prior authorization alone across the U.S. healthcare system runs into the billions of dollars annually. Let that sink in. Billions of dollars not spent on care, spent on paperwork. For patients, these administrative costs are part of why healthcare is so expensive. Every time you hear healthcare is unaffordable, part of that story is the billions spent on administrative burden, not care. You have a voice in this. Advocate with your employer, your elected officials, your insurer for streamlined processes. For practice managers, start tracking your authorization labor costs. Calculate hours spent per week on auth related tasks, calls, submissions, follow up, appeals, and multiply by your average hourly rate. Then benchmark that against your denial rate. Is the amount you're recovering in overturned denials proportional to what you're spending to get there? This analysis often reveals that better upfront processes, thorough submissions, solid clinical documentation templates cost far less than reactive rework. For healthcare leaders, authorization administrative costs should be a line item you can see. If your revenue cycle reporting doesn't isolate auth related labor and its downstream impact on denial rates, write offs, and delayed cash flow, you're managing blind. Invest in technology, AI assisted prior authorization tools, payer portal integration, automated status tracking, and measure the ROI. The business case is almost always there. So the prior authorization gets denied. What happens next? One avenue is a peer to peer review. This is when the treating physician, the one who knows the patient, who examined them, who built their care plan, gets on the phone with a physician employed by the insurance company to make the case of why the treatment is medically necessary. In theory, this sounds reasonable. Doctors talk to doctors. Clinical minds engage. A good decision is made. In practice, it can be anything but. The reviewing physician may be in a completely different specialty from the one relevant to the case. They may have spent minutes on a file that represents months of a patient's healthcare journey. And they are, at the end of the day, employed by an entity whose financial incentive runs in the opposite direction of approving the claim. Your doctor, who was also trying to see their other patients that day, carves out time during lunch, between appointments, sometimes early in the morning, to re-justify a decision they already made using their medical training and direct patient knowledge. Sometimes peer-to-peer succeed, the denial gets overturned. Sometimes they don't, and every single one of them represents a physician spending professional capital fighting a battle that shouldn't have to be fought. For patients, if your claim is denied and your doctor recommends a peer-to-peer review, ask them to do it. And ask your doctor afterward, what was the outcome? What did they say? You deserve to know what argument was made and how it was received. If the peer-to-peer fails, ask about an independent external appeal. Most states and federal law give you that right. For practice managers, create a peer-to-peer tracking log. Document every request, date, payer, physician reviewer, outcome, and turnaround time. This data tells you which payers routinely deny and then overturn on peer-to-peer, which is a signal that the initial denial may have been unwarranted. That pattern matters in payer escalations, contract discussions, and regulatory complaints. Healthcare leaders, your peer-to-peer overturn rate is a powerful number. If the majority of peer-to-peers are overturning denials, that's evidence that the initial denial process is flawed, not the clinical decision. Document it. Present it to payers in contract negotiations. And if patterns persist with specific carriers, consider whether regulatory complaints or payer escalation pathways are warranted. Some states have enacted prior authorization reform legislation. Know where your state stands and engage your advocacy organizations. After all of this, the authorization requests, the delays, the peer-to-peers, the appeals, sometimes everything falls through and the patient gets the bill. This happens more than it should, and it happens in more ways than most people realize. A procedure is done urgently, and there's no time to get a prior auth. A provider assumed no auth required meant covered. An authorization was granted, but the claim denied for a technicality, a wrong modifier, a diagnosis that didn't precisely match, a place of service code that was off. The authorization expired before the date of service. The wrong provider rendered the care. And when the claim is denied, the provider, facing mounting operational costs, bills the patient, or the insurance company issues an explanation of benefits that leaves the patient responsible for the full amount. Patients who trusted the system, patients who assumed their insurance would work, patients who are now staring down a bill of thousands of dollars for a procedure their doctor told them they needed. This is not an edge case. This is happening every day to real people. And often these patients don't know that they have the right to appeal. They don't know they can ask for an itemized bill. They don't know that they can negotiate. They don't know that they have options because no one has ever told them. That's why this channel exists, so that you know. For patients, if you receive a bill you weren't expecting, do not pay it immediately. Request an itemized bill. Request an explanation of benefits from your insurance company and compare the two line by line. If a claim was denied, ask why, in writing. You have the right to appeal. You have the right to ask for a payment plan. You have a right to negotiate. And depending on your situation, you may have protections under the No Surprises Act or your state's balanced billing laws. Know your rights. Use them. For practice managers, patient financial communication is a front-end responsibility, not just a billing department problem. If your team can't clearly explain to a patient what their likely out-of-pocket will be before a procedure and what happens if a claim denies, you are setting everyone up for a painful conversation later. Invest in pre-service financial counseling. Create a clear written communication about coverage uncertainty. The conversation is uncomfortable before the procedure, but it's catastrophic after. For healthcare leaders, your patient financial experience is part of your patient experience. Bad debt, charity care write-offs, and patient complaints about billing are often downstream symptoms of broken upstream processes, missing authorizations, poor benefit verification, inadequate pre-service communication. A dollar invested in pre-service financial counseling and authorization workflow almost always returns more than a dollar in improved collections and reduced write-offs. Measure it, fund it, make it a priority. Here's the bottom line. Prior authorization was designed as a guardrail. a way to ensure resources are used appropriately. And in concept, that's not an unreasonable idea. But what it has become in practice is a system that delays necessary care, burns out physicians, consumes enormous administrative resources, and leaves patients financially exposed for care their doctors ordered and their insurance theoretically covers. This is not an accident. It is the result of policies designed to protect payers, built inside a system where patients, providers, and healthcare organizations often don't know their rights, don't have their data, and don't speak up until they're already in crisis. That changes when you're informed. Patients, know your policies, know your rights. Ask questions before your procedure. Don't assume. Practice managers, build systems that catch problems before they become denials. Track everything. Communicate clearly with patients before the bill arrives. Healthcare leaders, this is a strategic issue, not just an operational one. Measure it, fund solutions, advocate for reform. Your organization and your patients are counting on you. Now, before I let you go, I want to tell you about something we are building that I'm really excited about. Everything we cover on this channel, the processes, the policies, the business of healthcare, it all exists inside a much larger story. And that story has a darker side that deserves its own dedicated space. We are launching companion episodes, which are audio only, called The Dark Side of Healthcare. Think of it as the next level of this conversation, where behind the business of healthcare gives you the knowledge and the tools. The dark side of healthcare takes those same principles and processes and shows you what happens when the system isn't just broken, it's being exploited. We are going to talk about corruption in healthcare, the ways it happens quietly, systematically, and at the direct expense of patients every single day, all across this country. It is going to be more raw, more investigative, and more uncomfortable than anything we've covered here. And that is exactly the point. I want you to listen, not because it's easy to hear, but because you cannot advocate for change in a system you don't fully understand. And the patients being impacted by this corruption deserve people who are willing to understand it. The link will be in the description and comments below when it drops. Make sure you are subscribed here and following the channel so you don't miss the first episode. If this episode helped you, share it. Pass it to a patient who's confused about a bill, send it to a colleague who's drowning in authorizations, tag a healthcare leader who needs to see this data. And again, if you want to hear the full interview with Dina, the link is in the description and comments below. She has over 18 years of wisdom in that conversation, and it's absolutely worth your time. Drop your questions in the comments. I read every one. Your questions shape what we cover next. I'll see you in episode 6.